morning, everyone. I'm Dr. Supika from Prince of Songkhla University. I would like to open this section, the morning session, which is the AOSOR RCRT-RST conjoint session. And the theme of this session is imaging of pediatric emergencies. We have the invited speakers. Two are from the International AOSOR and ASPR organization, and one from Thai speaker. This room is international room, so we will run the session with the English language. Okay, let's start with the first one. The topic is imaging of abdominal neonatal emergency, and the speaker is Dr. Nattinee Leelakanok. She is now working at the Department of Radiology, King Chulalongkorn Memorial Hospital. Please welcome Dr. Nattinee, please.
Good morning, everyone. Quite an early session today. I hope my session can wake some of you up and prepare all of you for our great session that will come after. Okay, let's start. I have nothing to disclose, but I just want to say thanks to Dr. Panuthai for some of the images courtesy. My topic will be in case. It's not that rare case, just a simple case, but I have some points to share with all of you, so I hope it will be useful. The first case is a 1-month-old boy who is irritable and presents with an acute bilious vomiting. His plain abdominal radiograph reveals an airfilled gastric bubble without evidence of distal bowel gas. So, which further investigation do you need? This case, we proceeded with an upper GI study. The upper GI study shows normal distension of the duodenum with a beak-like configuration at its end here, without contrast passing through the more distal segment, and these findings are consistent with midgut volvulus. Midgut volvulus usually occurs in neonates with pre-existing midgut malrotation, and it is commonly presenting in a previously well neonate with an acute onset of bilious vomiting. About 60 to 80% of cases present in the first month of life. However, preterm infants are less likely to present with bilious vomiting, but may display non-specific signs and symptoms such as apnea, gastric retention, abdominal distension, and maybe present with shock and necrotic bowel at the operation. In midgut volvulus, the duodenum rotates clockwise about the axis of the SMA and obstructs at its third portion. This condition can be associated with duodenal stenosis and annular pancreas. Radiographs may be normal at the onset. The duodenum is not typically distant as seen in duodenal atresia. If distension occurs, it usually subtle. During an upper GI study, the duodenum typically twists in a spiral, wrapping around the axis of the SMA, creating a corkscrew appearance, and then ends in a beak-like shape, as we shown in the red arrow here. So I have the companion case. This case is a 7-day-old boy who is also presenting with acute bilious vomiting. The plain radiograph shows an airfilled gastric bubble with decreased distal bowel gas. But this case we designed to not to proceed with an upper GI study, but instead chose to perform an ultrasound. On ultrasound, you will see the duodenum at the outer edge of the twist. Here, with the twisting of SMV around the center of SMA. So this was diagnosed midgut volvulus. An upper GI study is typically performed in cases suspect of midgut volvulus. However, ultrasound can also be used as a diagnostic tool, offering the benefit of no radiation exposure. On ultrasound, you can see the duodenum and SMA twisting clockwise around, the SMV twisting clockwise around the SMA here, which what we call the whirlpool sign. However, the whirlpool sign may not be visible in patients with bowel ischemia because the perfusion was reduced or absent. And in patients with gaseous distension of the bowel, the gas will be obscuring the ultrasound beam. Also, the ultrasound may confirm the flow of the SMA if we see SMA within and distal to the volvulus. Other modalities that can be used for diagnosing midgut volvulus may be CT, but typically we do not perform it solely for diagnosis. Instead, we usually done when other clinical signs are suspect, such as when diagnosing the acute, the cause of the bowel obstruction, and then midgut volvulus is incidentally identified. So let's move on to the second case. This case is an 8-day-old preterm infant present with lethargy, feeding intolerance, and abdominal distension. Her abdominal radiograph on the 6th day of birth and after birth shows diffuse airfield dilatation of multiple bowel loops. Like this here. And on the 8th day, there is pneumatocyst intestinalis seen along the bowel loops in the right-sided abdomen. We see this in the morning, show it by yellow arrow. And then in the evening, we see this here is portal venous gas. I don't know, it's a little bit faint here. So we see pneumatocyst intestinalis and portal venous gas. These are important clues for diagnosing necrotizing enterocolitis, and I will call it NEC. NEC is an inflammatory condition that affects the GI tract of neonates. It most commonly occurs in premature infants who are receiving enteral nutrition and is the most common surgical emergency in newborns. Frequent follow-up or periodic imaging is important, especially in patients with advanced disease. Complications can include short bowel syndrome and stricture. This table shows modified Bell staging criteria for NEC. Stage 1A suggests a suspect diagnosis. 1A and 1B suspect diagnosis of NEC. The patient may present with abdominal distension and blood in stools. Plain radiograph may be normal or shows myelus. I will have the example of case later. Stage 2A indicates a definite diagnosis of NEC with mild severity. The patient may present with absent bowel sound and maybe have abdominal tenderness. Plain radiograph show ileus and pneumatocyst intestinalis. Stage 2B confirms a diagnosis of NEC with moderate severity, which there is abdominal tenderness and maybe cellulitis. Radiographic findings are like in stage 2A plus portal venous gas and ascites. Stage 3A indicate a definite and severe form of NEC. Abdominal finding includes those of stage 2B along with signs of peritonitis. Radiographic findings resemble those of stage 2B plus prominent ascites and persistent bowel loops. And stage 3B represent the most severe form, accompanied by bowel perforation, which we will see as pneumoperitoneum on the plain radiograph. So this is the abdominal radiograph from our case at the 6th day. As I have shown you previously, shows diffuse bowel ileus and suggesting stage 1A or 1B. Film on the first day, on the 8th day in the morning, show pneumatocyst intestinalis along the bowel on the right side abdomen here, suggestive of stage 2A. And film from the 8th day at the evening, show portal venous gas here and pneumatocyst intestinalis here, suggests stage 2B. And this is another case here. It's the companion case. We will see that there is persistent dilatation of the bowel loop here with ascites. So this indicating stage 3A. And This one, we will see the lucent liver shadow here and double bowel sign here. So this is pneumoperitoneum and suggestive of stage 3B. Ultrasound can be used to diagnose NEC as it provides real-time direct images of the bowel and fluid. It can detect complex ascites in cases of bowel perforation, though pneumoperitoneum may not be always visible. Key ultrasound findings include focal fluid collection, free fluid with internal echoes, bowel thinning or thickening, absent bowel perfusion, intramural gas, and portovenous gas. This ultrasound image demonstrates focal fluid collection with internal echo here. Intramural gas is seen on ultrasound as a bright echogenic foci along the bowel. You see that this is intraluminal gas which caused artifact here, but this is intramural gas. You see air in both dependent and non-dependent portion of the bowel. On power Doppler ultrasound, portovenous gas appear as small. Sorry that doesn't have the video clip, but we can collect evidence of portovenous gas by using Doppler ultrasound that will show bright speckle along the power Doppler. Extensive portovenous gas is seen as punctate at linear branching areas of echogenicity within the portal branch, as this image. Image here describes sequence of changes in bowel wall thickness. Image 1 shows a change of bowel wall thickening but with increased blood flow. In image 2, the bowel wall thickening is persists but blood flow has decreased. Image 3, bowel wall starts to slough off and then the bowel wall becomes thinner and blood flow still remains some. In stage 4, sloughing continues, the bowel becomes thin and the blood flow stops. The progression of these changes can be vary between patients, but in some cases it can happen quickly and you might see these later signs on the initial abdominal ultrasound. So this ultrasound image shows bowel wall thickening and increased blood flow. This ultrasound image shows thinning of the bowel wall with decreased and absent blood flow. Later, I have read the interesting article from Pediatric Radiology, so I want to share with all of you. It's suggesting the role of abbreviated ultrasound in evaluation of necrotizing enterocolitis. This paper aims to identify high-risk sonographic findings without requiring a focus on bowel assessment, so it will be useful in out of service hour, like when we are on the night shift. These high-risk findings include pneumoperitoneum, here, complex free fluid, and focal fluid collections. So the sensitivity, specificity, positive predictive value, and negative predictive value of the abbreviated NEC ultrasound are all quite high. So this abbreviated ultrasound can be clinically useful in predicting poor outcome, especially during off hours when resource may be limited. So may be useful for some of you. So we proceed to the third case. The third case is a 2-day-old boy present with abdominal distension and bilious vomiting. This is the film from the first day of life, showing absence of the abdominal gas with faint calcification along lateral abdominal wall and faint calcification along hepatic surface here. And then the patient underwent ultrasound, which revealed free intraperitoneal air. You see that the probe is in mid-abdomen. The air appearing as a bright echogenic area with reverberation artifact here. And the air was disappear after compress, as in this image. Ultrasound on the second day also show multiple bright echogenic foci along hepatic surface and along peritoneal lining. And there is ascites with floating debris, which is meconium. Ascites with meconium is also seen in the scrotal sac, likely due to a patent processus vaginalis. So the operation confirmed a perforation in the terminal ileum in this patient. So this case is meconium peritonitis. Meconium peritonitis refers to a sterile chemical peritonitis resulting from intrauterine bowel perforation and spillage of fetal meconium. The meconium spilled in the peritoneal cavity leads to an intense inflammatory reaction with fibrotic tissue formation and calcification. In the majority of cases, the perforation has closed by the time of birth. Mortality in patients with meconium peritonitis is higher if the perforation persists until birth. Imaging findings that predicts the need for surgery include intestinal obstruction, ascites, volvulus, and pneumoperitoneum. So this is the fourth case now. A 7-month-old girl presents with sudden non-bilious vomiting and irritability. This is plain abdominal radiograph, show a retained feeding tube here with air-filled gastric distension, and you still see the distal bowel gas. So what imaging investigation would you do next in the case of vomiting? So we choose upper GI study. The upper GI study shows that the antrum and parolus position superiorly to the gastric fundus and EG junction with a twist of the stomach here. This finding suggests mesenteroaxial gastric volvulus. Gastric volvulus is an abnormal rotation of the stomach greater than 180 degrees around its long or short axis. It can present acutely with sudden, persistent abdominal pain or present chronically with intermittent episodes of abdominal pain, vomiting, and gastric distension. It is associated with conditions such as congenital diaphragmatic hernia, diaphragmatic defects, heterotaxy syndrome, and wandering spleen. So, again, another companion case. This is a 4-year-old boy who presents with abdominal pain and vomiting again. His radiograph shows no obvious gastric distension, maybe it's gastric bubble around here, and no significant bowel dilatation. So we do upper GI study. On the upper GI study, the greater curvature of the stomach was found above the lesser curvature of the stomach. Is in reverse position, showing a twist along the stomach long axis, which suggests organoaxial gastric volvulus. So gastric volvulus has two types. The mesenteroaxial type is more common in children where the antrum and the pilolus displaced above the gastroesophageal junction, while the organoaxial type, the stomach rotating around its axis, showing reverse position of the greater and lesser curvature of the stomach. And these mesenteroaxial types tend to present acutely, but the organoaxial type tends to present more chronically and intermittently. So I have a little bit time left. I have a bonus case. It's just an easy case one. This is a 1-day-old boy presents with bilious vomiting. His plain radiograph show, you see that it's double bubble size, large gastric bubble here, and the duodenal bubble here. So it's quite easy that we are diagnosing it as duodenal atresia. Duodenal atresia is believed to result from failure of recanalization process. It can be linked to conditions like Down syndrome, esophageal atresia, or Hirschsprung disease. If the obstruction is above the ampulla of water, it might present with non-bilious vomiting. In unusual circumstances, air can be seen distally in a patient with complete atresia. If the patient has anomalous bifid common bile duct, meaning that it has separate insertion into the duodenum above and below the point of atresia, and then air can pass from the bifid bile duct distally. Okay, so take-home message. Midgut volvulus can also be diagnosed using ultrasound. Ultrasound and color Doppler ultrasound are helpful in diagnosing NEC by assessing bowel thickening or thinning, bowel perfusion, and fluid. In meconium peritonitis, signs such as intestinal obstruction, ascites, volvulus, and pneumoperitoneum point to the need for surgery. Mesenteroaxial gastric volvulus is more common in children and typically presents with an acute fulminant onset. On the other hand, organoaxial gastric volvulus usually has a chronic intermittent presentation. Well, that's a wrap of my session today. Hope you all found something useful or gained some knowledge from my topic. Thank you for your attention and hope you guys enjoy Thailand.
Thank you, Dr. Nattinee, for the all wonderful cases. And although it's not difficult case, but they are common, and she shares some teaching points for clinical practice and also good for the board examination. We have can you queue up the QR code for Q&A session? So you can scan the QR code for Q&A session, and we will keep all the questions at the end of the sessions after all three speakers finish talks.